good morning, everyone. I'm Jason Ng from Biomedical Imaging Department. So it's my great pleasure to introduce you to our speaker this morning for our breakfast at UMHealth today, Dr. Wei Lin. Dr. Wei Lin is a medical lecturer, consultant interventional radiologist, and the head of interventional radiology unit in our center. So as a consultant IR specializing in peripheral vascular and non-vascular interventions, she pioneered thyroid and parathyroid ablation in our center and was among the first interventional radiologists in Malaysia that introduced this service. So she has then since played an instrumental role in advancing this technology, this technique in the region, and now actively involved as a trainer of this procedure in this region. So this morning, she will be speaking on a procedure that relatively new in our service. Some or most of you may not have aware of this technique and procedure service available, yet it's actually increasingly performed due to its expanding role in management in selected patients that have a certain thyroid and parathyroid conditions. So interventional radiology offer minimally invasive treatment options that allow patients to be treated under local anesthesia and favor a promising outcome. So through this session, Dr. Ng will share her expertise on thyroid and parathyroid ablation, covering its principles, clinical indication, and the current outcome that we have for our patients. So please join me and welcome Dr. Wei Lin this morning. Dr. Ng, over to you. Thanks.
Thank you for your kind introduction. So today I will be sharing about minimally invasive management of thyroid and parathyroid diseases, the role as an intervention radiologist. So the outline of my topic today will be brief overview, how we select patient based on guidelines, how we prepare, the technique, complication, and the cases that we have done over the past 1.5 years. So the main indication for referring to intervention radiology is if the patient has a solid cystic nodule causing compression, that patient does not want operation, or patient has high risk or contraindicated for surgery, hyperthyroidism. This is a new papers that are coming up to say that low-grade papillary thyroid CA, stage T1A and T1B, which is less than 2 cm, may be amenable for ablation. However, the most patients referred to me, actually this main indication. These patients, they have a large lump at the neck. They don't want surgery. Patient high risk for surgery. Patient who do not want surgery. Okay, these are the main referrals that I get. So why choose thyroid ablation instead of surgery? So if you do a surgery, you may risk the whole thyroid being taken out, or hemithyroid. You need to take a lifelong thyroid replacement medication. If you do thyroid ablation, you can see the scar. There's no scar. There's maybe a small nick at the skin. If you do a thyroid surgery, you have a big neck scar, may need to have a tube. The recovery process is also longer. Normally for ablation, we do as outpatient, but now we do inpatient. We monitor for 1 day to look for any hematoma, and we discharge the next day. Okay, and we do it under minimally invasive technique, which is just using local anesthesia. We don't need to do under a general anesthesia where patient need to be intubated. So how do we select patient? So this is the CPG for thyroid nodule management. When patient present with thyroid nodule, first, yes, they have to go through a primary physician, take a proper history, a physical examination, take biomarkers, and also ultrasound neck. So if patient's thyroid function is normal, they will go through a risk stratification using ultrasound. We use a thyroid score, and I will show you what is a thyroid score. If your thyroid function is elevated or decreased, then you need to do further studies, by which in the end you still need an ultrasound for risk stratification. And if needed, an FNAC, which is cytology, meaning a cellular confirmation. So this is a ACR thyroid score. We base this on the appearance of the nodule on ultrasound. So cystic, mostly is a benign, TR1 and up to TR6. So if the size, we base on the echogenicity, the morphology, the calcification, the capsule, the appearance, and also the size. So as you can see here, if the size is more than 2.5 in a thyroid tree, we would subject the patient for a FNAC, which is a biopsy, fine needle cytology. And if the patient has a benign lesion, then we can proceed with this ablation. So this is a paper. This is a systemic review of 63 papers from different countries: Korea, Italy, Austria, and United Kingdom. So what is their practice? Their practice is if the patient has a lesion, they will check whether the patient has toxic or non-toxic, and then also whether the FNAC is benign or not benign. So in our center, we practice getting an FNAC, only one result. We don't need two results. Okay, some centers they need two benign results before proceeding with microwave ablation. So this is another algorithm for a non-functioning benign thyroid nodule, symptomatic, asymptomatic. So symptomatic patients that doesn't want any surgery like this, cosmetic concern, yes, we will classify whether it is a pure cyst, solid, or mixed cystic and solid nodule. So for ablation, we have different types of ablation. We have thermal and also alcohol ablation, where it's called ethanol ablation. It's a non-thermal ablation using just a liquid called ethanol. Okay, but however, if the patient does not want this ablation, they can choose to go for surgery. There are different types of thermal ablation. There's laser, RFA, HIFU, microwave. So if you compare the other modalities, we don't have laser because laser is more for smaller lesions. RFA, we have RFA and microwave. I will explain further the two difference. HIFU, we don't have this service yet. Maybe in the future, once we get a HIFU machine, we can also use this as an alternative treatment. However, the machine is expensive and it doesn't really penetrate the cystic component of a thyroid lesion. So what is thermal ablation? So there's actually two types of thermal ablation, heat and cold, cryoablation. And this technique is used in other organs, tumors such as liver and renal tumors. It has been used many years in the treatment of HCC. So for thyroid, it's not new. I think it has been done for the past at least 10 years. We only started this service in UM for the past 2 years. So the goal is to create a irreversible cellular damage to the lesion. Okay, so tumor can be benign and malignant. So for these benign tumors, we do not need a margin like how we treat the HCC. So our goal is to actually shrink the lesion. Okay, so for coagulation necrosis, we need up to 50 degrees Celsius. Okay, but we do not want it too high. If it's too high, it will cause vaporization and carbonization of tissue. So the machine has a mechanism that will burn up to between 60 to 100 degrees. So a lot of you will be confused with radio frequency ablation and microwave ablation. So thermal ablation actually started with radio frequency ablation using electric current. However, the conduction energy is a bit lower. Now with the new technology, microwave ablation, they use electromagnetic energy, which can burn up to 915 megahertz. And for radio frequency ablation, we have other things that we need. We need grounding pad. There is a heat sink effect. The size is for smaller volume. Ablation zone may not be predictable compared to microwave ablation, and it takes longer time. So I would prefer microwave ablation now. So for other cystic and solid lesion, like I mentioned earlier, if there is about 20% of solid component in the mixed solid cystic lesion, I would suggest to do a combination of chemical and thermal ablation, meaning this is a cyst. where we can, let me show you the point. So this is a cystic, this is an echogenic lesion. So first we aspirate the cyst, we collapse the wall, we inject the alcohol to ablate the wall. So alcohol, we use absolute alcohol about 99.7%, where it scleros the wall of the cyst. And if there is a residue solid component, we will introduce the thermal ablation, which is the microablation, and burn off the residue wall. So for thyroid cyst that has less than 20% of solid component is a very straightforward treatment. So not all nodules are solid. So some comes less like a cyst. So we aspirate. So if you just aspirate out the cyst without doing any thermal or chemical ablation, there is a higher risk of regrowth of the cyst. So when we aspirate the cyst, we inject alcohol, and the recurrence rate is much lower. So this is an example of a patient. This is a pure cystic lesion. I think there is some solid component at the border. So first we remove the cyst, aspirate all the cysts, and then you can see this is the leftover solid lesion. Then the needle for ablation is introduced, and we ablate the lesion. So post-ablation, the lesion will look with a different morphology, will look like this, heterogeneous. So when we follow up the patient, we should be follow up in the same center that the lesion was ablated, because then we can, if you go to another center, they may call this as a Thyroid's 4 or 5 lesion and ask for a FNAC, which is not necessary, because these appearance are just post-ablative changes. So for preparation, this is the category of procedures that are done in intervention radiology. So we have simple procedures, which is classified as category 1 and 2 and 3. So this is a basic procedure like a line, setting line, central venography, that is not so invasive. Category 3, such as tips, renal biopsy, ablation, nephrostomy, biliary intervention that requires a needle puncture through an organ. We need blood results. INR must be corrected below 1.5, platelet less than 50. Okay, if you are taking antiplatelet, we need to also withhold it for 5 days. If you're taking Plavix and other medication. So what do we explain to the patient? We need to explain that this is a different concept than surgery. Surgery, you remove the lesion entirely. For ablation, for thyroid nodules, the lesion first must be confirmed to be benign by FNAC, and the patient must understand that the lesion is still within the thyroid lobe. Okay, and the aim is to decrease the size, the volume. Okay, we follow up the patient 1, 3, 6, and 12 months, and if there is a residue or it does not reduce in size, we can always re-ablate the lesion. There may be a bit of pain because it's done under local anesthesia, but we give local anesthesia around the capsule, so patient will not feel pain. We also give some IV sedation. Complication and side effects, I will explain later. Also get past medical history, including details on the medication and surgery. Need to withhold all the anti-platelet, and admission and observation, and what patient need to look out for post-procedure. So the drugs that we give during the procedure is IV methylprednisolone and paracetamol. This is for the pain and relief and to reduce the inflammation. And our emergency drugs is also the methylpred and cold saline. Okay. So how we position the patient. So this is the head. We stand behind the head, and this is the ultrasound machine in front of us. This is the machine. So we use a 16 gauge needle for thyroid and 17 gauge needle for parathyroid lesion. And we have a spinal needle to inject a cold fluid for hydrodissection. And also we need an IV line to give medication. So this is how the ablation needle look like. It's similar to ablation done for renal, for liver, and for other organs. Okay, this is a very small needle and very sharp needle. So these are the danger area that we want to try to avoid. Okay, there are many nerves here. The danger triangle here consists of the recurrent laryngeal nerve. Also, there is a esophagus here. Also, a recurrent laryngeal nerve has variation all along this area. Middle cervical sympathetic ganglion, so the carotid artery, and also the vein and the vagus nerve. So how do we prevent thermal damage to these structures? We need to do this technique called hydrodissection. Hydro means water, dissection means displacement. So we can use different liquids such as cold fluid, crystalloid liquids, dextrose, saline, also colloid. Colloid actually, like Woluben, can stay in the has a better stability in the space. However, in our center, we just use the dextrose saline. There's no complication with using dextrose saline. So this is the technique of hydrodissection. This is the thyroid nodule. This is the esophagus. This is the nerves here. And then this is the carotid space. So because there are planes in the neck, so we inject the saline here, or dextrose, and we displace the thyroid and the nodule. So there will be a safe plane when we ablate. So after hydrodissection at the planes, this is the ablation needle where we target the nodule, and we ablate this without injuring any structures around. So this is a very relatively safe procedure. So this is one of the complications that may occur if you get injury to the recurrent laryngeal nerve. So on the right is a normal vocal cord movement that we can see on ultrasound. So before doing any ablation, we can scan the vocal cords. We can see this in this patient, both sides are moving equally and symmetrically. On the left, you can see that the right side is moving, but it's not moving equally and symmetrically slow. It's not moving. It's just a movement, but it's not opening and closing. So there's a suspicion of a vocal cord injury. So sometimes this can happen transiently because when I give the local anesthesia, the local anesthesia may also fall into this space and also can anesthesia the vocal cord, the nerve. So it will just be a temporary. And also we give the emergency medicine, which is the prednisolone, if there's a vocal cord paralysis, which may help. So technical factors that affect volume reduction rate. So we measure volume reduction rate as the success, whether the procedure is successful. We measure this rate, reduction rate. So when we follow up at 1 month, 3 months, 6 months, and 1 year, we measure the volume of the lesion. Okay, so in micro for thyroid ablation, I use normally 20 to 30 watts compared to the liver and renal where we use up to 100 watt. So in thyroid ablation, we ablate the peripheral margins, but we don't need a good margin, just only the border of the lesion. Okay. So if we have shear wave elastography, if we have a lesion that is high, means it's very stiff. Elastography is measuring the stiffness of a lesion. So the more stiff the lesion, the response is a bit lower. So in parathyroid ablation, parathyroid is a bit more tricky because it's not in the thyroid itself. It's normally inferior to the thyroid, which need more hydrodissection. So in parathyroid ablation, the target is to ablate the polar artery to prevent recurrence. Okay, as mentioned earlier, hydrodissection is needed to better ablate the nodule margins and to protect it from complication. So this is an example of a thyroid lesion. So how we can approach this lesion if you're standing at the head of the of the patient. We can do it transisthmus or lateral approach, also depending if you're a left-hander or right-hander. Actually, we can use both hands to puncture it. And you can position yourself either in front or at the back of the patient, depending on how comfortable you are. Post-procedure monitoring, we observe for 30 minutes. As usual, we monitor the vital sign, heart rate, blood pressure, oxygen. So during the procedure, sometimes I give a bit of meta and fentanyl just to calm the patient. Patient is still conscious, but will be sedated. So post-procedure, we assess for stridor, cough, any hoarseness of voice. If there's any concern for voice change, we should refer to the ENT for any assessment. Check with the laryngoscope, which is the gold standard. Okay. Laryngeal nerve injury can cause patient to cough when swallowing, and patient should be given a sip of water first before allowing orally to gauge the risk of laryngeal aspiration. Okay. Patient should be counseled on identifying early complications such as hematoma, and you should come to emergency immediately. So complication, as mentioned earlier, voice change, it can be during and immediately after ablation due to the local anesthesia. The rate of recurrent laryngeal thermal injury is low, 1.4%, which also is a complication if you do a surgery. Thyroidectomy also will have risk of recurrent laryngeal nerve injury. They also may have post-hemorrhagic inflammation, fibrosis around the nerve, which so far I've not seen. So follow-up, as mentioned earlier, we use our volume reduction rate as the treatment goal, up to 50%. So volume reduction rate is higher in cystic nodules than in solid nodules. So how we measure, we take the initial volume of the pre-ablation and post-ablation and divide by initial volume and times 100 and get a percentage. So the meta-analysis of outcome in RFA, because they started with RFA, so the papers are mostly on RFA. The volume we see at 6 months is 64.5%, at 12 months 76.9%, and at 36 months 92.9%. So this is because of the scarring. So after ablation, definitely you will get some inflammation. You may not see the effect immediately, but when you follow up at 6 and 12 and 16 months, you can get up to 92% volume reduction rate. For biochemical evaluation, so most of the cases normally are euthyroid. Hypothyroidism following chemical or thermal ablation of thyroid nodule is rare. If there is a hyperfunctioning nodule that requires ablation, we need to follow up the T4 TSH, and the aim of ablating a hyperfunctioning thyroid nodule is so that patient can be drug-free. So once you ablate the hyperfunctioning thyroid nodule, you need to monitor and see whether you can discontinue the drugs. So when do we offer additional ablative session if the nodule does not reduce more than 30% by 3 months or there is regrowth? So there's a question you may ask, will these lesions become cancerous or not? By right, it shouldn't. I don't think there's any papers that show malignant transformation of the lesion. But however, we must insist that the patient undergo an biopsy before doing the ablation. So these are the cases done in both PPUM and also in UMSC from May 2023 to December 2025. We've done a total of 14 thyroid nodules and 9 parathyroid lesions. So I just show you the case example. So this was the first patient that I've done. This is actually a doctor that referred herself to me because she heard about thyroid ablation and wanted to ablate this lesion. So FNAC was done. It's a benign follicular thyroid nodule. So it's also a very good location to ablate this lesion. So she also had another lesion, a mixed solid cystic lesion. This is a colloid nodule, very benign appearing lesion. So this is post-ablative changes where you can see air and also these ill-defined margins. These are the ablation zone. These are immediate post changes. So you see, it's actually very fast. It's 30 watt, total time of 26 seconds. And the other one lesion was 1 minute. So the ablation time is very fast, but however, the preparation with hydrodissection, giving the local anesthesia may take 10 to 15 minutes. So the whole procedure is about 30 minutes. But however, there's a learning curve. So it's not every patient is also different. So you need to counsel the patient. So after follow-up, you can see the lesion looks like this. It's a rim of ablative zone and then some echogenic lesion here. So post-ablation in 2 months, there's an immediate reduction of 56%. However, this patient didn't come for follow-up and she's scanning in another place, but so far there is no other complaints from her. This is another example of a cystic nodule with solid component here. So I counseled patient for both thermal and chemical ablation. So after aspiration, you can see the solid nodule here. And then we also ablate, I think I ablated in the second session post thermal ablation. So this is alcohol injected and this is the thermal ablation. You can see the air. Follow up a few months later, you can see much smaller with the rim of ablative zone. And another follow up, much smaller. So I follow up this patient up to 6 months. As predicted, there is a 98.6 reduction. This is another young man that refused to go for op. He has a diffuse goiter. No, not really definite nodules. He's euthyroid. Thyroid function is normal. And he wanted to get his neck a bit smaller. Okay, I don't have a picture of him, but this is the diffusely enlarged thyroid lesion, thyroid lobe. So I ablated the nodules. This is pre and post. And there is a significant volume reduction, okay, up to 85%. And he's much happier now. And he wanted to re-ablate, so I'll be ablated him 3 times. And the thyroid function is still normal. So I'll show you some hyperparathyroid cases. So for hyperparathyroid, because it has hormones involved and calcium and PT and phosphate involved and medication involved. So usually we do this with the endocrine team on board. So this patient is a Prof. Lim's patient and the endocrine team. So this patient, 81 years old, she has a hypercalcemia due secondary to the superior right PTH adenoma. She's on medication and reduced dose and then been on this other medication, denosumab. And for multiple, since 2023-24, she's having hypercalcemic emergency. And they finally referred to us. On ultrasound, this is a large lesion, and she's a high risk for surgery due to athatic ascending thoracic and atrial aorta. So they decided to have an ablation done. So before that, we must make sure this is confirmed is a hyperparathyroid lesion. This is a scintigraphy with a SPECT CT done, confirming the hypermetabolic adenoma. So this is quite a straightforward lesion. We put in the needle and ablate the lesion. And follow up 1 month ultrasound, there's a reduction of 56%. We can see the lesion is less hypervascular. So it's very important that you have the endo team on board because they need to admit 2 days prior, start on calcitrol, check the calcium albumin phosphate IPTH 2 hours ablation, and for a few days after, monitor for Henry bone syndrome, and also alert NS if there's a possibility of hematoma after ablation with typical LVA. So this is the chart post-ablation. You can see it should be exactly the same as how they do the surgery. The PTH should drop right after ablation. You can see it dropped and still maintaining. Also the calcium level maintained and phosphate level also increase. So when do you achieve the normal level for IPTH, calcium and phosphorus after microwave? In 2 hours, you can sorry. Yeah, this is the goal, and post 1 month, it should be normalized. So the goal is in 1 month, we can expect the changes to be normalized with the volume reduction volume of up to 34%. And up to 18 months, you can get, up to 1 year, you can get 96%. I'd like to share the last case, which is also similar rat parathyroid lesion, which is much smaller than the previous. You can see this is the normal thyroid gland, and this is inferior to the thyroid, which is a bit difficult to get, but not impossible. So what we did was do hydrodissection. You can see the fluid below the parathyroid. It pushes up, it lifts up the lesion, so it's safe. We have a safe margin to ablate. This is post-ablation changes. And this patient did very well. Currently, his bloods are all normalized and not taking any medications. So the take-home message is thermal ablation for benign nodules and parathyroid edema is an alternative to surgery. It's minimally invasive, has a faster recovery time. So if thermal ablation is also should be offered in relapsed cystic lesion where they failed ethanol ablation. Residual solid nodules should be ablated with thermal ablation. Okay, so you need to be patient because follow-up is needed up to 1 year to assess the full treatment, assessing the volume reduction rate. So this is the team in UMMC where we divided, we have a neuro and body intervention. So this is the current team in body intervention. Okay, thank you very much.
Thank you, Dr. Ng, for the comprehensive talk. So we are open for Q&A session now that we have a question from the floor. So if primary care detect a non-toxic cystic nodule, can we refer for ablation or go through endocrine first?
Because in UMMC, we don't have clinic and we don't have ward. You can refer us to the clinic, but the primary team would need to see first for the ward, to admit to their ward. So in primary team, you can refer to endocrine or ENT, I guess.
Oh, okay. So the next question will be, what is the criteria for referral for both thyroid and parathyroid nodules?
So in UMMC, patient with thyroid lesion would be seen by either endocrine team or ENT. So if the patient choose not to undergo surgery, the primary team will also refer to us if the patient does not want to do surgery. Of course, the best outcome for large goiter would be surgery. However, if the patient has high risk, they can always refer to us.
In continuation to this question, I would like to ask Dr. Ng, is there any criteria that you will say, this patient is not suitable for ablation? Because like a liver lesion, sometimes after a certain lesion, we will say, oh no, this is not suitable for ablation. Does that have any criteria in thyroid or parathyroid? You will say, this patient will not be suitable for ablation?
For thyroid, you need to do ultrasound, get the FNAC done, because one of the requirements, it must be benign lesion before ablation. So size does not matter, like the guy that has diffuse goiter. So besides thermal ablation, we also can offer embolization. So another new upcoming treatment is thyroid embolization. So all the organs in our body are supplied by arteries. So we actually can go and select each thyroid arteries and reduce the vascularity, causing necrosis of the thyroid lesion. So very important, must make sure there is a benign lesion. So whether the lesion is too small or too big, for thyroid, there is no cutoff size unless you are doing a PTC, which you need to have a T1A or T1B. For parathyroid, there's also no cutoff values. However, like parathyroid, from our experience, for primary parathyroid, it tends to be bigger and single. But if it's a tertiary parathyroid, there are multiple. It's more difficult to treat tertiary hyperparathyroidism. because the pathology is from the kidney. So as long as you have end-stage renal failure with tertiary parathyroidism, it always be stimulating the parathyroid. So it's best is surgery unless the patient has any risk factors. So the primary parathyroid tend to do better in the cases that I've done so far. Tertiary not so good, but it just buys them time.
Okay, I got a question from a student with me now. So just now, Dr. Ng mentioned that there can be a temporary vocal cord palsy during the procedure. Is there any follow-up protocol that we engage in this kind of patient?
For vocal cord, I think one of the first few cases I did was a very difficult case because patient had previous surgery and had a recurrence. So we went into ablate, and patient did have vocal cord palsy. So she went for scope and also went for physio. So they have I think ENT they have some physio they can do for the patient. I think slowly the patient got a bit better.
I see. Okay. I think if there's no other question, I got one last one for Dr. Since this is a relatively new service available in our practice, is there any specific barriers that you find to have during as a starter, as a pioneer in this practice?
Because intervention radiology doesn't have our own ward and our own clinic, so we don't get direct referrals because we don't have a ward. So I think in the future, if we get our own ward, observation ward, our own clinic, on regular clinic, if the patient can directly come to us, then we definitely have more patients to treat. So far, almost all of my patients are direct referrals in the private under UMSC. So hopefully the endocrine or ENT, if they want patients to get ablation done, they can refer to us in our IR clinic. Actually, we do have IR clinic where the patient can meet us and get counseled by one of the IR.
Thank you, Dr. So, is there any other question from the floor? Otherwise, I think we're okay to end the session now. Thanks. I think that's all. Any final message from Dr.
No, that's all. Thank you. And IR is we can do many things. You just have to come and talk to us. We are open for any new techniques or any procedure that other primary team would like us to accommodate. Anything can be done.
Okay, thank you,
Thank you.
Dr. Thank you everyone who joined the session. Thanks.